And I was trying to see what else they use, but all the other drugs they don't use for a chemical cardiac arrhythmia.
Okay, adenosine. So here's the thing with adenosine. It's used in part as a diagnostic. So if somebody's, like that guy at 200 and 230, his heart rate's 230.
Yeah.
Adenosine, at that point when you do 12 lead, all you see is brrr. You can't, you cannot analyze the wave. So adenosine slows it way down, so you can see what kind of an aberrant, what's going on, what the dysrhythmia is. And in some cases, it can actually do a cardioversion. It will put them back on track. The thing that's interesting about the adenosine is
short, like 10-second half.
Well, it's ATP.
That's right.
Adenosine triphosphate. That's why it has such a short half-life, because the body says, "Oh, good, we're going to just suck that up."
Yeah.
But it stops your heart for 2 to 3 seconds. That pause
is maybe enough to let it restart.
Yeah, it kind of and it slows everything down. And
yeah.
But if you don't know that it's going to stop,
yeah,
it could be a bit of a surprise. Oh my God, it's hard.
I killed him.
Yeah. Anyway, no, the real point of that was your observational skills. How many people really are there? What are they doing?
Yeah, I said 7, but I think I counted one person.
It's between 5 and 7. It's hard to tell. What do you think of his reaction to being shocked?
And I thought it was appropriate, actually, and I'm glad they gave him the Versed.
Well, he was on propofol as well. No, I guess he was just on Versed.
Yeah.
But anybody else on Versed would have continued to be out. That jolt was enough to have him. Now,
he was woozy.
10 minutes. Well, that's because he's on Versed.
Yeah.
10 minutes later, he won't even remember the procedure.
Yeah.
But that's the thing about Versed also.
Yeah. Now I'm guessing it was like the primary RN.
Well, there was, okay.
So he said it so fast that I couldn't really hear, but it sounded like he said 4 and 6 of adenosine, and then 12 and 24 or something, and then the Valsalva, and none of that worked.
Yeah, so
he said it so fast, we're like,
yeah, that's why I have to listen. Yeah, and I'm trying to remember because it's been a year since I last listened to it.
Okay.
But basically, they had tried a series. It was a stepwise approach, and that's they escalated their approach based on his lack of response until they finally decided, okay, we're going to shock him.
I'm amazed that he was like sitting. I don't know. I thought somebody that would be like that tacky would be like, I don't know, out of it or something. But he was just like, yeah, it's fine. Go ahead.
I'll talk about my own experience in a minute here, but about 10 years ago, I was going through phases where I was having similar, over 200. And I was doing fine until I saw the monitor, and that's when I got scared.
Yeah.
Because I'm like, well, shit, I'm 60. I shouldn't be going over. I was going to 212, 215.
Just sitting there.
Just lying there. Because it's a reentrant syndrome. So the impulse goes down, comes back, and it bounces back and forth. If you look up WPW, Wolff-Parkinson-White syndrome, that's one of the famous ones.
Is that the same as the PSVT?
Well, PSVT means P stands for paroxysmal, which means it happens. You have it's sort of random in its initiation. And then SVT just means supraventricular tachycardia. What that says is something in the atria is telling the ventricles to beat. We don't know what that something is. Is there another foci that's firing, or is it some other syndrome? There can be lots of things. So that's a very general term, and the paroxysmal part says it's not always like this.
But it's happening.
Things can trigger it. It comes and goes.
Okay.
That's all it means.
So what were you saying about WPW?
Well, that's a famous one.
So it's not the same.
He wasn't in WPW, but he had a reentrant syndrome. So if you look up reentrant dysrhythmias, you'll find WPW among them. but it has a different kind of characteristic look to it. And I had a similar, but not actually WPW. So they went in, they did an ablation. They shot a catheter up, and they basically shoot microwave at the interior of the heart if they can figure out where these aberrant pacemakers are and zap them.
But you had to have a cardioversion too?
Luckily, I never had they were going to cardiovert me, and then the diltiazem worked.
Okay. Calcium channel blocker.
Yeah, which I'm still on. I guess we should
I'll let you go.
start thinking about it. I'm sorry, you're late, you have to leave? No, you have 30 seconds.
Late with a cup of coffee, Amanda.
It's better to be late with a cup of coffee than early and no caffeine.
Oh, I like that. Next time somebody says late with a cup of coffee to me, that's what I'm going to say. I like little snacks.
Well, that's because I've had 2 cups of coffee. My brain is almost working. Well, shall we give it a try?
Yes.
I hear lots of rumbling about, it sounds like you guys are working on your thesis topics.
Yes.
Having I didn't do a master's thesis. I did a seminal, a capstone paper kind of thing for my master's. Part of the trick is to get that question as narrow as possible, because all of a sudden you're writing a 100-page paper and they don't want that. Sounded like you're looking at communication protocols. You might look at a broader topic than just communication between like EMTs and the ED, and just about, you might want to look at research on like radio-based communications, because they're all going, whether it's the cops or the military, communication's a big deal, and how do you effectively transmit a lot of information in very few words? So you might expand your search to see if there's other things outside of nursing that will support your thesis, if you have a thesis yet. Anyway, that has nothing to do with pharmacology. How's it going so far? What did you guys think of the little quiz? I haven't looked to see if were you all able to get in and do it? Was it hard? Indifferent? Easy? If you did,
you're going to say you're going to make
no, I won't make it any harder. I just thought, if you did the reading first, did it help?
Yeah.
Oh, good. Well, I like that. That means you might actually know something about what we're talking about today. So today we're going to talk a little bit about antidysrhythmics, and the way I set Pharm 3 up, originally I may modify it a little bit, but originally I looked at what Dr. Harris is covering, and I am trying to be more or less, tied with what she's talking about as well, so that you have a couple things to hang this stuff off of, instead of just we're randomly talking about antidysrhythmics as opposed to diuretics or something. And 12 leads, it's been long enough now since I actually took a lot of 12 lead EKGs and read them, that I'm no longer really very good at 12 leads. I can recognize fatal dysrhythmias, which, by the way, for the NCLEX is what you need to be. You don't have to read a 12 lead for the NCLEX. But you need to know what these are and what these are.
Tombstone.
That's a tombstone rhythm, yes. Why is it called that?
Because it's shaped like a tombstone.
What else does it mean? Why else is it? They're dying. Yeah. So these are, this is a 4-beat run of PVCs, 3-beat run. So the thing about PVCs, premature ventricular contractions. So it says somewhere there's another cell in the myocardium that's telling the ventricles, because we're talking about V's and A instead of A's, atria, says, oh, you should fire. Why are these, do you know why they're a wide complex instead of a narrow complex rhythm? You're kind of on the right track there. Why is it slow? Do you know?
Is it because it's not repolarizing fast enough or depolarizing fast enough?
Okay. Oh, no, we're going down the wrong path there. So we're gonna back up. So normally, a normal conduction pathway starts in the atria, runs down through the Purkinje fibers, and is transmitted out through the heart, so that all the muscle contracts in synchrony. And you know that, by the way, the contraction is not like this. It's actually it's like wringing, a wash rag. When you get a PVC, what happens with these other? It's no longer using the conduction pathway, and the other aspect of the heart, which is one of the things that sort of keeps us alive sometimes. Have you heard the term an escape rhythm or read about it yet? If you hear the escape rhythm, as my ACLS instructor used to say, it means escaping death. You'll have a heart rate of like 30. And it's a ventricular rhythm because the atria aren't participating. But anyway, the reason that this is a wide... Yes, ma'am.
That's when the SA node isn't controlling it?
Isn't doing it, yeah. You get escape rhythms when you have like a third-degree block and they're totally dysfunctional. The reason for a wide complex is that some other cell in the heart says, oh, I think you should fire. And now instead of going through the conduction pathway, it's cell to cell all the way around the heart. And so you get this, it does take a long time, comparatively, to this which says, boom, oh, we're all gonna fire, we're all in agreement. Here it's, oh, I fired, and you should fire too, and you should fire too, and everybody around me starts firing, and it just sort of, propagates itself around the entire myocardium. So this first one, these are, PVCs. PVCs may or may not be concerning. Depends on the situation. Most of us actually have them at one time or another. That little flutter is like, that felt weird. However, if it's in your intensive care and you see somebody like this and he's throwing these 3 and 4 beat runs like every minute, that's concerning. Now, it could be due to electrolytes, it could be to some other issues, whatever's going on. Maybe, he's post-MI. So it's more the frequency with which they're happening and how long the runs are. Because you're not effectively pumping when you're doing this, because it's not a coordinated beat. So I'm going to step back from this for a second. What did you all miss? You guys, everybody usually loves extra credit. So did you all watch the video of Mr. Homeless guy that's been drinking and is running it? He was running it about 2:30? 2:55. So let's think about a heart rate of 255. That's 4 beats per second, right? About, more or less. Yeah. You're late. No. So that says you have 250 milliseconds in which to relax, fill up, and beat. So what's going to happen to the filling efficiency of the heart? Yeah, because really what it means, you have about 1/10 of a second for the heart to actually open up and fill with blood. So do you think that might have had an impact on why his blood pressure was so low? There's no output because there ain't no input. It's just, his heart's just doing this. If you think about 250, that's why you can't read the EKG. That's why they had to slow him down. I think if you listened to it, you heard they had tried adenosine earlier. Adenosine does 2 things. One, in some cases, it will actually help cardiovert certain kinds of rhythms. And in the other case, and in both cases, this is something that you, as a nurse, need to know if you're administering it. The heart will stop for about 2 or 3 seconds. Now, the patient won't know about it because their eyes roll up, they're gone. They don't know. They were just, oh, hi. So adenosine has a really short half-life, 10 seconds. Because you all know what adenosine is. You've all heard of ATP, right? Well, that's adenosine. So the way you administer this is, you hold their arm up, you have the IV set up, and you go, and it's got to get there like right now. So actually, the closer you are to the heart with your IV, if it's down here, it's too far away. It probably needs to be in the AC. Better yet, if you've got a central line. Heart stops, and then when it starts back up, it starts out slower, and they can get a better read with the 12 lead of what really is going on. The P in there is paroxysmal, and it just means they have these random moments of usually like AFib. So SVT, supraventricular tachycardia, says it's something in the atria. It's above the ventricles that is driving the heart rate, as opposed to something in the ventricles driving the heart rate. So that's all that means. Anyway, he had quite the experience. He was on Versed, he was kind of hot, he was gone, and then they bang, and he's like, what the hell did you do to me? 20 minutes later, if you talk to him, he wouldn't remember the event. That's because of the Versed.
I like how honest the doctor was.
Those are the good docs. Okay. This is going to feel like somebody hit you with a baseball bat, because that's the truth. Because all those muscles, they contract in synchrony with that. I mean, that's a hell of a jolt. And it's not just that the heart. I mean, all of the muscles react. Bang. So Anyway, what did you think? Was that kind of a cool? We're all a little sadistic. Was that a cool video? Oh wow! Look at that. I'm sorry.
His beard stand up. It made his beard stand up.
Okay. Okay, so this is getting back to this part. Was there anything anybody wanted to share about that video before we actually get back to the actual lecture? Anything you observed or thought was cool or weird? I appreciate your comment about the honesty. That was you said that, right? Yeah, good ER docs they tell you straight up front. Do you all remember in med-surg when I talked about compassionate cruelty? You're honest with the patient. This is going to be uncomfortable, painful, if you want to use that word, but it's only going to last this long. As long as people know how long they're going to be in pain, they usually can tolerate it. It's going to be a minute and then we'll be done, or 2 minutes. If you say an hour, you might have less cooperation. Anyway, tombstone, yes. This is called a monomorphic ventricular tachycardia. Why is it monomorphic?
One shape.
Yeah, they're all identical. Cool. And this is actually a normal EKG. This is kind of what you want to see. And these are the different leads. You'll see the AVR, the V1, V4, V2. And that's when you do a 12 lead. By the way, there's not 12 leads with a 12 lead. If you count the cables, there's only 11. The 12th is actually implied or inferred. It's calculated. See if I can describe this effectively. In essence, with an EKG, you've got these sensors that are looking at, the charge, the electrical change as it passes, as it comes towards it or goes away from it. So if the electrical charge is coming towards it, the wave goes up. When it passes, it goes down. And depending on where your leads are placed, it's looking at the heart from different perspectives. It's like looking in through a window over here or here. And so sometimes it looks like it's always going away from you. So that's why some leads are inverted and others are not. Because it's just where they see, how they see the perspective of like, well, it's always going away from me as opposed to it's always coming towards me. Now, if you're working in the ICU or you're on telefloor and you're looking at something and it's like, my God, that looks weird. Check to make sure the leads are not reversed. It happens all the time. They go in, they take a shower, the CNA comes in, they plug things back in, and they have swapped them. And that will make your EKG look very different and not good. Do you guys know the various mnemonics for like white over right or smoke over fire? Yeah. 12 leads are not hard to hook up. not easy to read, but the hookup is actually quite simple. I still remember being called into the down to OB, which was across the hall, in essence, from us in the ICU. 4 o'clock in the morning. We have a patient. When she needs to have a 12 lead, and I'm like, yeah. We don't know how to take a 12 lead. Okay. So it's like, oh, come on, you're working in a hospital. We're all supposedly ACLS certified, and you don't even know how to hook up a 12 lead? Give me a break. Okay. Let's move on. So a flutter. When we're talking about atrial flutter as opposed to AFib, flutter is actually a regular. It's a regular irregularity. Does that make sense? It's, you don't see a flutter too often. It comes and goes, as it does here. But the way you're going to it's a version of atrial fibrillation. It's actually a little more coordinated, but it's still, instead of being a singular beat telling the ventricles to do what they're supposed to do, you've got all these extraneous beats in the middle. And how do we treat that? Well, beta blockers are good. Calcium channel blockers. What do calcium channel blockers actually do? What's the physics there? So what is?
It decreases the irritability of the heart because of positive ions.
Let's go back up a little further. What does calcium do in terms of myocardial or any muscle tissue? That's right. So if you block that channel, it's going to slow the contractility down, right? We're going to talk a lot about beta blockers a little bit later, but how many beta receptors, what kind of beta receptors are there in the heart?
Beta 1.
Because we have unless we're Doctor Who, we only have one heart. Any of you watch Doctor Who? Mm-hmm. Yes, 2. But that's because he's from Gallifrey.
It doesn't make him any friendlier.
No, it doesn't. No. And beta 2s? On the lungs. And we're going to talk about this actually in depth, but the challenge with a beta blocking drug, if they're non-selective, even if they are selective, they can act to a certain degree on both sides. When you stimulate the beta 1, actually when you block the beta 1s, your heart rate slows down. When you block the beta 2s, you increase, you get asthma attacks, the bronchial spasm. So that's why when you give people beta blockers, there's always concern if they're asthmatic that they might actually have it might exacerbate their asthma. And if they're non-selective, you can almost count on it. But even the selective still have some crossover. Am I talking about anything that makes sense here? Am I even following my notes? So this is AFib. Now you can see that's really just erratic. So with aflutter, the atria are beating rapidly but in synchrony and more rapidly than really the ventricles can respond to. With AFib, there is no synchrony. It's, they're doing this now because everybody's marching to his own beat. And you won't see any P waves in here. You just get random stuff. And you'll notice that the ventricular contractions are irregular. And the reason they're irregular, there's two halves to that. One is some of the impulses get through and tell the atria to beat, the ventricles to beat. But it's kind of random about which ones, and they have to be in a certain part of their recovery phase. And of course, then there is, and I think I mentioned it at the very start, this escape rhythm. The ventricles have their own pacemaker. So if they're not getting enough signals or correct signals from did I say atria? The ventricles have a pacemaker. There's multiple pacemakers in the heart. The one you want is the SA node working right, because that's the one that really controls everything. But if it fails, then you have the AV node, and then you have the even further down, and there's an intrinsic, the heart. Every heart cell, every myocardial cell actually has its own intrinsic pacemaker, and that's what will drive like the escape rhythm, where they'll all agree, okay, well, we still need to beat. We want to stay alive. Again, basically you're going to treat AFib and aflutter with these beta blockers, calcium channel blockers. And as someone who has, luckily I never got cardioverted like the guy in the video. I responded to diltiazem, but some years ago I was, I came to work and I said, I'm not feeling real good. I'm having troubles making it up the hill. So instead of going to work, I walked into the ED and said, I think I'm in AFib. If it's a new onset AFib, any idea what that does to somebody's experience of, their exercise tolerance, how they feel, their ability to stand up and walk around?
Probably be more tired.
What do?
Can't you feel it?
Some people are more aware of it than others, but yeah, I can.
My father-in-law could.
Hmm?
My father-in-law, he would go and
Yeah, and you'd say, oh, I'm having it again. How much does the atrial kick contribute to the overall cardiac output? Atrial kick is that, everything's relaxed, and then sort of at the last second, the atria are supposed to contract, and they supercharge. They kind of overfill the heart a little bit, and then, of course, as that starts to fill up and come back, that's what closes the valves, so that then the ventricles can close. But the atria do contribute to the overall cardiac output. And if you remember what that number is, it's about 25% of your cardiac output. So if you go into AFib, your cardiac output has probably dropped about 20 to 25%. That's why you notice it, because all of a sudden it's like, not as much blood is getting to the brain, let alone, the organs and the muscles. So getting back to the drugs, beta blockers overall control, overall rate. Calcium channel blockers impair conduction. I mean, you can think of it as, it's a designed impairment. And we're going to slow them down. PSVT, I said, no, I can't even say paroxysmal. PSVT, heart rate, and sometimes over 200. So we can, again, diagnose with adenosine, and it may even cardioavert with it. The beta blockers are again, intended to slow them down, keep them out of that range. Somebody who has PSVT, the things that can trigger it would be, they can be dietary, like caffeine, stress, so anxiety is not a good thing. Being dehydrated. Changes in your hydration can leave somebody more susceptible to AFib. So if they stay well hydrated, they're less likely to go into AFib than they are if they're dehydrated. So the actual ventricular, the filling and the pressure in the system all play a role. Calcium channel blockers, same thing. So we're still at the moment talking about either trying to control the rate or slow the conduction, or both. I take both. And if I run out because I'm not paying attention and all of a sudden I forgot to order from Kaiser my mail order meds, I know about it. After a couple of days without my meds, I start getting runs, and I'm aware of it. What is something that the doctor can do that you can't do in an attempt to control somebody who's an AFib or rapid AFib? Vagal maneuver anybody can do. So what's a vagal maneuver? What do we do?
When you hold it.
You bear down. Yeah, like,
You can also do that.
Excuse me, yeah. You can have a vasovagal response, a Valsalva. They both start with a V. Okay. Well, there is something a physician can do that we can't do. Yeah, you're close. There's an actual name for it.
Is that where you do the elbow in the chest or something?
No, that hurts. That's called, no, that's a karate move.
It's also a wrestling move.
Yeah, you'll get a penalty for that one in wrestling. I used to wrestle.
Elbow.
No. Okay. Carotid massage. Which works effectively for me. I can do it to myself. The doctor can do it. Me. Can a nurse do it? No, because it's outside of our scope of practice.
Is that because there's the receptors?
Yeah, and so what basically is you're telling, a little bit of carotid massage tells everything, slow down, pause. Why do you think we're not supposed to do it? What if they have plaque in their carotids? Could you break that free and send it to the brain? Luckily, I know my carotids are clean because I've already had a carotid ultrasound a couple times. Yeah, they go. They look for what they look for is turbulence in the flow. Does it blow through, or is there, is it like the babbling brook? So yeah, that only doctors get to do that, or the patient can do it to themselves. I do it from time to time. I forgot what I was going to talk about. Well, it'll come back. Yeah. Yeah, when you get to the point where you're starting to fade away, don't do this while you're driving. Not a good.
Why?
I don't know. We don't have time for that story. So PVCs, premature ventricular contractions. There's also PACs, which are premature atrial. Yeah. I don't know if we'll talk about those today or not. But typically what you're going to do for these are lidocaine, amiodarone, and beta and calcium channel blockers. See, these guys keep showing up. These are rate control. Lidocaine has been around forever. It's cheap, it's effective, so we don't use it. We use other more expensive things. But, well, the lidocaine has its issues too. Although it's handy. It's good to know. What can amiodarone, what is one of the, if you read about amiodarone, what side effect does it have that you need to be really cognizant about? Well, it could lead to torsades, yes. Yeah, but what is your hint that your patient is heading that direction? If you were to look at their EKG, there's no, they're at that point they're
Before the tombstone?
hopefully long before the torsades and tombstones. No.
So you're talking about a side effect, one of the major side effects.
So it prolongs the QT interval. So the time between, the first and the next beat, in that T wave. So the closer the T wave gets to the peak, the QRS, that's not good, because what you can get is and my ACLS instructor Ron T, he said, you can get a Ron T, a R on T. So when you get the bang of the R in certain portions of the T wave, that can trigger torsades. And so with amiodarone, which can extend and drag out that T wave to the point where you can get an R on T, that's why it's concerning. So when you have a person on, a patient that's on amiodarone, you are paying attention to that QT interval to see, is it getting longer and longer? Because that's a risk. So let's talk about the different ventricular. So this is PVCs. Actually, when you have a run of 4 or 5 beats, that will be considered ventricular tachycardia. So you'll report that to the doc as, he's having runs, 5-beat runs, 6-beat runs of VTAC, or you could call it, a 6-beat run of PVCs, but The thing is, again, this is, and when it's non-sustained, when it's irregular and intermittent, it's less concerning. But if the frequency gets, if they're getting closer and closer together, or the runs are getting longer and longer, you want to be figuring out what's going on. Why is this happening? This is a, sustained tombstone. Call a code. You'll walk in and the patient's going to be, the eyes are going to be rolling up. They may be talking to you. They can actually, some people actually can tolerate this for a while. Got it. So lidocaine, amiodarone, and then we're doing a code. So this is torsades. So you get this interesting pattern. Kind of looks like a slinky, It's a fatal rhythm. So if you're, when you're taking the NCLEX, when they present something like this or that, these are the ones you need to be able to identify. This is going to kill my patient. You're not going to be asked to differentiate first degree, second degree, third degree block, because that's not typically part of a new grad's experience. Most new grads don't work in the ICU, even though a lot of them do seem to get jobs in the ED in particular, and they should be able to recognize this stuff. But the NCLEX really is about, are you going to keep your patient alive in most situations? VFib can be regular or irregular. So like that, and it can be coarse or fine, and it can go in and out. What's happening in VFib? How is that different from VTAC?
The ventral dysrhythmia.
So in VTAC, you actually are getting a beat, even though it's not being coordinated from above. In VFib, there's no beat. It's just, we're back in jello mode, but it's the whole heart now. And the treatment is ACLS. You're going to be doing CPR.
So in VTAC, depends on how fast it is, but it's able to send out blood because it's getting a beat?
Yeah, VTAC. So VTAC is going to be, depending on the rate, it's a less effective way to beat. But if it's a regular VTAC like that monomorphic, that's why some people can tolerate it, because they're actually getting blood flow. They have cardiac output. Since it's not coordinated with the atria, of course, you've got a loss of efficiency there. And depending again on the rate, getting back to this idea of like this guy earlier who was running at 200, you have less fill time. With less fill time, there's less cardiac output. So, if somebody's in VTAC at 160, they're probably not conscious. If they're in VTAC at 100, they may actually be there. Yeah, but his was a PSVT, not. See, he had a narrow complex. The difference is that the ventricles are beating in a coordinated fashion with PSVT. So the atria are sending all these impulses, and the ventricles are responding in a coordinated way. So he actually is getting a good beat. With VTAC, you're getting this wide, complex, less efficient beat. And so as they go faster, they really go downhill. Did that make any sense at all? Yeah, sometimes it's hard to differentiate. What you're talking VTAC, VFib. For the first exam, you want to know this stuff. There will be questions on the different classes. I'll tell you right up front.
Subclasses or just the class 1, 2, 3, and 4?
No, you're going to need to know A, B, C. You really, there's a couple of questions in there. You have had fair warning. Let's see, I've given procainamide, lidocaine, phenytoin. all the beta blockers. Amiodarone, sotalol, which is a beta blocker, verapamil, DILT, DIG, and I've given most of those at one time or another. So if you work in critical care, you're very likely to see a lot of these drugs. Particularly somebody who's come, maybe they had a code, they made it to the unit. So yeah, you want to know how these drugs work, what their primary purpose is, where they act. In the big classroom, I'd put the slide up and people say, I can't read that. Yeah, I know, it's a problem. You also want to know the adverse effects of a lot of these. Okay, now what do you expect with beta blockers? Yeah, bradycardia, hypotension, dizziness, fatigue, AV block. Yeah, sure. What is an AV block? You probably haven't talked about this yet in med-surg yet.
AV block.
Mm-hmm.
Atrial ventricular block.
There you go. You've just described it.
So, I'm going to guess. I have no idea.
What?
I'm going to guess it's when the signal does not get from the AV to the ventricle.
Effectively. So it may just be delayed, or it may be totally not there. So that's kind of where the first degree, second degree, third degree come in, just to give you a preview of coming attractions. First degree AV block says has been some kind of damage. Actually, the message does get through to the ventricles, but it's slowed down. And the way you determine that is the time it takes from the P wave to the QRS. So if that overall time is less than 0.2 seconds, 0.2 down to 0.06 or something like that, that's normal. If it exceeds 0.2, then it is now first degree AV block. What do we do for that? There you go. Actually, one of my students last year, on Code Blue Day, the day that you're going to have in the sim lab, we took EKGs. Women, you bring your sports bra or whatever, or bikini top if you want to have a 12 lead done. So we did 12 leads, and one of my students says, his PQ, he was 0.22, very healthy. I said, you are in first degree block. You might want to talk to your doctor about it. There's probably nothing, but so it doesn't necessarily cause problems. Second degree block is just longer, and there's what you'll see in second degree block is now instead of being consistently just delayed, and actually the P wave kind of marches further and further away until you miss a beat. And in third degree block there is total dissociation. The atria are beating, the ventricles are beating, but they don't know about each other. So that was, I ran out of slides and I have time left. What questions do you have about rhythms and blocks and stuff?
I have a question about the drugs.
Okay. We'll see if I can answer.
Well, do you need to know specifically every single one of those drugs?
No, the classes.
Just the classes.
No, the classes and the most common drugs. When you look in the text, they talk about amiodarone. They don't talk so much about lidocaine.
Yeah.
But the drugs that the book focuses on, you'll get into those, and there's a whole list of drugs. The profiles, yeah. Go for the top 3, top 2 of in each class. That's because those are the ones that are most commonly prescribed.
Well, that's what I want to know, because sometimes the book gets into really out there
Arcane, weird,
really,
like nobody's ever seen before.
Right now and fill my brain with.
Yeah.
I just need what's important.
Did I put up on Moodle the 50 most commonly prescribed hospital drugs? Mm-hmm. Yeah, that's part of your guide. Okay. Look at those, especially the ones that are around the heart, amiodarone. Yeah, you're going to know the calcium channel blockers, know the most common beta blockers, understand how lidocaine works and amiodarone work. And at that point, you should know about digoxin.
Cardiac, like
Yeah, glycosides are a big deal. What are the concerns with glycosides? What if you have somebody on a glycoside?
Potassium.
Exactly. Are glycosides chronotropes or inotropes?
Aren't they both?
Yes. You win. Okay. So what's a chronotrope?
Slows down the contraction.
Or?
Conduction.
Okay, chrono just means time. So it can slow it down or speed it up. Epinephrine will increase your heart rate. Yeah, so a chronotrope changes the time base. It can move it up or down. It's not limited to just they slow things down. If you think that way, you're going to get burned. So a chronotrope just says it controls rate. An inotrope controls
Contraction or the conduction?
strength and contraction, right? And there's another trope in there that suddenly... Thank you. Remind me what dromotrope is, since you remember the name.
That's conduction.
Conduction. Thank you. You know, even Nurse Bob has his moments of like the brain's no longer working. The ones that we deal with most, well, we do actually, we deal with all of them. And I think, you know, when we think about things like the beta blockers and adrenergic and all that good stuff, I think where people get lost, particularly with the beta blockers, it's kind of like how they work. And one of the analogies I came up with last semester, we'll see if it works for you guys, hopefully better. When you're talking about receptors, what I kind of like to think of is a key and a lock. So if I put a key in the lock of that door, can any other key get in there at the same time? So as long as that key is in there, it is blocking that receptor. And that's what a beta blocker does. It happens to fit the beta receptor in such a way that nobody else can land on it. And it blocks access to the beta site so that the normal neurotransmitter can't get there and tell it to speed up. Does that make sense? So, you know, and how long you block that site for is going to impact on how much you control the heart rate with a beta 1 blocker. So if something is blocking, and you don't actually block all the beta sites because that would be not good. But the point is to slow things down. That's why we get beta blockers. Somebody that has for whatever reason has had an intrinsically increased heart rate. And we're not even talking about things like don't get old.
More coffee, Bob. More coffee.
Apparently.
More coffee.
Third cup, yeah. Oh, well, we'll save it for later because it's not today's discussion anyway. I'm thinking about the cardio and renal protective effects of another major class of drugs that suddenly have just escaped my brain. All I can think, never mind. That we'll talk about them next week. Other questions? What a cop-out. What else would you like to not know about? I hate running out of lecture. This is terrible.
I have a
The
question
first time
about
for everything.
Yeah. What was that?
for ACLS certification. Is it valid to do those online, or do you need to go? And
I mean, can you get ACLS certified without actually physically going to a class?
Yeah.
Not that I know of. You can get certificates, but then again, you can also get diplomas online that way. Yeah, your ACLS classes. Here's the deal. Here's my suggestion. My comments, thoughts. The job market is really rapidly improving. I still get email from Kaiser about a dozen a day saying we have a dozen new positions. So since October 1st, Kaiser has opened up almost 400 jobs within a 35-mile radius of my house. That's just 5 hospitals. Lots of jobs. As is, Sutter's hiring, everybody's hiring. They've all decided, oh, we don't have enough nurses. Get your ACLS certification after you get hired, because your employer will pay it. If you pay for it yourself, you want to be the hot. You're out about $300 to $400.
Yeah,
It ain't cheap.
Like $200-something online.
Yeah. You will be better served, and I don't think in the current job market, as things are improving, that having all those other certifications are really going to matter. If you pass the NCLEX and you're breathing, you're going to have a good chance of getting a job. And basically every hospital I know of now wants ACLS pretty much on every floor. So they say, once we've hired you, you have 6 months, we will send you to class. Get your certification that way. Save the money. You guys owe enough already. You're spending a ton of money to go here. I don't think it's a good financial investment at this point. 2 years ago, it might have made a difference, when there weren't any jobs and you were really trying to get yourself out there. But right now, I think the job offerings are going to be good. So I would be cautious about an online first-time ACLS. There's a lot of benefit.
I was like,
There's
if I go for my BLS, why
Yeah,
not go for
there's a lot of benefit. Actually, the ACLS classes I took really were good classes. And usually what it is the first time it's a 3-day course. And then renewal is 1 day. But it's 8 hours. And you go back and you go over all these rhythms. And you actually need to be able to look at they're simulated, but you look at a rhythm, you have to identify it. And it's beyond just the fatal rhythms. You need to be able to, identify a third degree. So we didn't talk about this at great depth, but for first degree block, it's observation, monitor. Second degree block may or may not be a pacemaker, depends on what kind of second degree block it is. But definitely observation. And third degree block is always pacemaker. Or whatever. Anyway, I can't think of anything else to say. If you have questions, you're welcome to ask them. And if you don't, we will see you again next week for a repeat.